project manager in my full-time role. The reason I'm here is I serve as a consultant data analyst to Specialized Healthcare and Medical Education Department, Government of Punjab. And also because PSIM was looking for, taking a sample so that we can, get a study in a way whereby diabetics, pre-diabetics, as well as those with a risk of cardiovascular diseases, we can ascertain that and also make sure what can be done to improve this in the healthcare setup of Pakistan. So the title is Prevalence of Obesity, Risk of Diabetes and Cardiovascular Diseases Risk in Participants of PSIM 2025. So in this 6th annual conference, we were able to ask a few people who were mostly doctors. Then there were people from various pharmaceutical companies, as well as certain people who were non-doctors, families and friends, maybe asking people randomly as well to bring in so that we can ascertain the obesity, the risk of obesity, risk of diabetes, cardiovascular diseases, or the risk of the same. Now the aims and objectives of this very sampling and then the ongoing study on it that we carried, the test that we carried was to evaluate obesity like mentioned earlier. Then there were risk of diabetes mellitus, cardiovascular risk in those with over 40 years of age as per the WHO guidelines. So a total sample size of 267 participants was there. They were mostly the attendees of the meeting in one way or the other. And it was conducted between 18th and 20th of April in Karachi, like we are here already. The methodology was the anthropometric measurements included height, weight, and BMI, and that was using the electronic and ultrasonic scales. Then we had body fat percentages, using the bioelectrical impedance and lab tests of random blood sugar levels and total cholesterol. Now this is the setup, and for that, obviously, I would like to thank Sami Pharmaceutical for being very supportive, providing us with the necessary manpower as the resources and the equipment. So in the first step, they were taking the blood sugar levels. In the next step, obviously, the cholesterol level was monitored, and then the blood pressure was taken. After that, there was, as you can see in the background on the right side of the picture, there is the ultrasonic and electrical impedance machine that would monitor the weight, the height, and the BMI of the body mass index of the said subject. After that, an evaluation was conducted on a piece of paper to know someone's diabetic as well as cardiovascular diseases family history, and with that, the score was established. These are some more photos of the sequence of registering the patient through this. So the diabetes risk was calculated using the ADA score, and cardiovascular risk was calculated using WHO's CVD risk for South Asians. For those aged above 40, there has been, a study was conducted, a lot of scientific research went into this, that people hailing from South Asia can actually get their cardiovascular disease risk calculated by minimal lab intervention because of the resources in this part of the world, so that even those not hailing from urban or developed areas can actually be able to get to know their cardiovascular disease risk, and at the same time this was aided by the World Health Organization. Now this is a chart. This, as we can see from the scale, was created. It is basically, it has 4 different axes in a 2-dimensional scale. On the left side, we have age. From top, down bottom, we see starts from 40, goes all the way up to 74. Those are the ranges essentially calculated. On top, we have bifurcated it into men and women. Then we have smokers and non-smokers, both within men and women. On the right side of the scale, we can see the systolic blood pressure. On the bottom, we see the body mass index. With that, this is applicable in the countries of Bangladesh, Bhutan, India, Nepal, and Pakistan. Essentially, that covers South Asia in particular, obviously, besides Afghanistan, and which has now been included as a part of the South Asian and Maldives. So with that, you see the scoring, lowered the age, lowered the BMI from then onwards within men, and obviously women further lower down. You can calculate a person's risk by knowing the age, the habits of smoking and non-smoking, the gender obviously, as well as the systolic blood pressure. with these 4 categories or 5 questions, you can get to know the CVD risk in a particular person, how prone is he to get cardiovascular diseases in near future. Then for South Asian people it is people without diabetes. Now there is another chart which obviously is constructed whereby you need to understand that the people without diabetes, how their scoring needs to be done. Obviously they would have a different methodology involved in it, and with that what needs to be done is again age, men, women, smoker, non-smoker, systolic blood pressure, and below is the total cholesterol level. That is the sole change which has come in this particular chart, and with that we would be able to gather the cardiovascular risk for people without diabetes in South Asian region. Last one is the smokers and non-smokers. Again, the blood cholesterol level being the baseline, while smokers and non-smokers bifurcated in a way that people are going to get the scores a little differently, and their blood pressures obviously at a slightly different scale. So South Asians who are smokers and those who are non-smokers, what chances do they have for having a cardiovascular disease based on this particular score is what this chart is going to tell. Now these are the results. Now these are essentially, since obviously all of us or most of us here, not including me, are doctors or are linked to the medical profession much more. I am related to data here, but with that what we were able to do at a very primitive level was that we were able to gather that 18% of the total population had a BMI of less than 23. Within that, obviously, there was variable figures. 266 people, 18% of the total population, 18% being males, 20% being females from within their own population was the percentage with a BMI of less than 23. Between 23 to 30, that we will categorize as overweight in our part of the world was 54 to 60%. So these are the people who would essentially be falling into the obesity category eventually later on. This has all been done during this conference, and while we were conducting the study, we were able to find out that the obese and severe or even morbid obesity might be there. We did not categorize it specifically. 16 plus 9, that essentially is 25% of the people. So 1 in every 4 person was actually obese, one way or the other, which is not necessarily alarming, but is something of a high concern. Next, we move to the body fat percentage. So here we see that the percentage for males is less than 19 being a reasonable percentage, and more than 19, this is the males category. 32 less than or more than for the females is the acceptable percentage, less than 32 being the acceptable percentage here. So it was categorized with 79% had a reasonable, acceptable body fat percentage amongst male and female, in which a higher percentage of women, as we can see from the numbers itself, was more, fitter than the males, or had the acceptable body fat percentage, the desired levels. Then we have 187 people who had a higher body fat percentage. That essentially means either they have moved to or would soon be categorized as obese going forward, and then their link towards having cardiovascular diseases is also elaborated in the analysis we have done. Again, a primitive one, because it's a study and a work in progress, is somewhat like this. So 37 people had a risk of 5 and above. That essentially means they would soon be diabetics out of the 267 people that we conducted the test on. From those 47, 37 males and 10 female, this was the bifurcation. If I just reiterate my previous point, there were 96 female participants in this study, and then the rest of them were males. So 12 were already diabetic males. 4 were females with somewhere around, who were already diabetics, and 10 are prone to that. Now we go towards the WHO cardiovascular disease charts. We have essentially taken it into numbers at the moment. Like I said earlier, being a very start of the study, which was just conducted over the last 2 days and is still in a work in progress, so that we can build it into a kind of data which turns out to be meaningful information. There is those in 20 to 30 categories, and more than 30 categories are the ones who are at high risk of having cardiovascular disease, moderate to high risk. So 41 males out of 196, if I remove it, out of somewhere around 160 males are at a risk Above 40. Okay, so yeah, the total population, thank you for correction, Professor Saab. So 41 males above 40, out of those above 40, we need to categorize them as well, that how many of the people fall into that category are at a risk of cardiovascular disease. 19 is the number for females above 40 that are actually at a high risk of having a cardiovascular disease. Okay, yeah. Do I need to elaborate that one? Okay, fair enough. Thank you. So this is what we have been able to gather. The obesity of 29% of male participants. So 25% of 29% of male participants were obese. 20% of the female participants were obese. Now the risk of diabetes mellitus, 37 males and 10 female participants were at risk of diabetes. 12 males and 4 females were already known diabetics. Now, if we come to the cardiovascular risk, as per WHO charts for South Asians aged above 40, 41 males and 19 females were at high risk, 3 males and 13 females had moderate risk. Now, that is probably all from my side, but what we want to tell most of the people who have joined us and who are here, that this is an ongoing study and we are going to continue to build that further, taking further samples in multiple different conferences and where we can get the data from, and would probably make it a meaningful information for the people in South Asian region to avoid getting diabetes altogether and also cardiovascular diseases. Thank you so very much.
Thank you, Ezaaz.